Menopause is one day, which is what people don't realize.
Okay.
It's just one day.
Say that to the camera.
Menopause is one day. It's not a highlight event. It's just a day.
Yeah.
And it is the day from where you haven't had a period for the last 12 months. Okay.
Is there a chance where you haven't had your periods for 12 months and then on the 13th month they come?
So what we used to say traditionally is that you might have your menopause or go into menopause around 51 years. That's no longer holding true.
Okay.
It's coming earlier. It comes earlier for African women and people of African origin.
So there's a question about your lips. So does your labia actually disappear?
So disappear is a bit of a strong word,
Yeah.
but yes, they can become really, really thin. In vaginitis for menopause, there's no change in the skin. You can't see like colors or whatever it is. There's no boundaries. And you can give vaginal estrogen. So there's creams, there's a tablet, there's a pessary, there's a ring. I love them.
Yeah.
They are so cool, those vaginal things. They really sort out my patients.
Hi guys, welcome back to A Dose of Health, the podcast where I give you not too little, not too much, but just enough information to help you make an informed decision. My name is Dr. Hope, and today I have a guest. She's called Dr. Muchiri, and she'll introduce herself. So let me give you that time.
Oh, what am I supposed to say?
See,
The things I like.
names are...
My names are Dr. Moshiri Docas. I'm an obstetrician gynaecologist. I am a lover of hormones. So my work spans between fertility to when hormones stop working in the way that we expect them to be, so into the menopause space.
Okay.
Yeah. And I'm an avid reader, continuous learner, lifelong learner.
What are you currently reading?
Oh. Books-wise, I'm reading a book by a guy who's an NHS doctor. He used to and still sees people who are dying. So he got a lot of wisdom from those people who are dying. And the one thing that people kept asking him is, how do I know what my purpose is? So the book is called The Purpose Code.
Okay.
I think Jordan Grumet, that's his name.
Purpose Code.
Purpose Code.
Okay.
The Purpose Code. So really nice book. And I'm not reading it because I don't know my purpose. I know my purpose, but people ask me that question. How did you know what your purpose or your vision is? So I'm trying to understand how to tell them how I found out. But yeah.
Okay.
Yes.
So do you recommend it?
So far, I usually recommend the books after I've finished
Okay.
so that I can do an evaluation. So they can,
So I will come back to that.
And listen.
Okay.
Yes.
Okay. All right. So I have a segment called A Journey to Inside Out. So there's a movie called Inside Out. I don't know if you've watched it or heard of it. No. Okay. You need to. In fact, there's two of them.
Okay.
So they basically just talk about emotions, why we have emotions and how they affect us and influence how we behave. So where are you emotionally or mentally right now as we speak? Deep breath in. Who's-a?
Emotionally and
Or
mentally.
And or
Yes. Mentally. I'm calm today because I had chamomile tea yesterday, which is like my go-to when I'm not breathing very well.
That's half life is long.
Yeah.
The effects are
4
still
days.
4 days.
4 days I get the effects.
Okay.
Yeah.
Okay.
Other people say it doesn't work for them, but
Yeah.
I will be very relaxed for the next 4 days.
Okay.
So I time when to take it because if I have big things happening or events or like work, I can't take chamomile tea.
Okay.
I'll be too zen and too sleepy for the next 4 days. Okay. Correct. I'm all right. I'm doing quite a bit of work in my research stuff. And I got some difficult news yesterday. Not difficult, but something that annoyed me.
Yeah. Hence the chamomile.
Hence the chamomile and lots of gospel music and zenning. But yeah, I'm good to be here.
Okay.
Yeah.
Karibu sana, first of all.
Thank you.
And before you even start,
Yes.
we like telling the people to subscribe. So if you haven't subscribed, just pause kidogo. I'm giving you time to press that button to just subscribe and follow us across our social media platforms. So A Dose of Health on Instagram, on TikTok, and wherever you listen to your podcasts. You can also follow me, by the way, by Dr. Hope Simiu. Do you want to plug yourself before you start? Are you on socials, first of all?
I'm on social.
Gani.
I'm on Instagram and I am on LinkedIn.
I knew you were going to say LinkedIn.
Why? Because I'm an oldie.
I didn't say that. I didn't say anything.
I mean, I have no denial about how old I am and where I'm at in life. But I've been encouraged to join TikTok, so I will.
Yeah.
But my socials are Dr. Moshiri.
Okay.
Across.
Yeah. We'll put that here.
I think even on Twitter,
You're still on Twitter?
I try.
Wow. I left that place a long time ago.
Yeah, I don't keep up with there.
Yeah.
But I'll try TikTok. I'll let you know how it goes.
Rating from 1 to 10. You'll give us your rating?
Yes. Yeah.
All right. So now, welcome to the doctor's seat. This is just like a small fun segment I do with now the guests who are doctors. And then if you're not a doctor, then I do the patient seat.
Oh.
Yeah. So for you, we'll do the doctor's seat.
All right.
So, first question is, if you had to explain what you do to a 4-year-old, how would you do it in 2 sentences?
I take care of women. Is that 2 sentences? You wanted 2 sentences?
1 or 2.
Oh, okay, yeah. I take care of women, and I say that broadly because I take care of women in communities, I take care of women in clinic, I take care of women as part of couples, I take care of women emotionally, mentally, physically. Yeah. People assume that when they come to a gynecologist that it's just gynecology stuff. A lot of the times there's more beyond that. So if we're talking about like hard topics like sexual intercourse, you might come for that, but there's some emotion behind that. So that's what I do. I take care of women. Yeah.
Okay.
Women and girls. I want to say women and girls. Yeah.
Okay. Yeah. Actually, you have to include the girls.
Yes,
yeah. So we had your friend a few weeks back, Dr. Masinde.
Oh,
yes.
She's my classmate.
Oh, really?
Undergrad and postgrad. Nonetheless, she's very clever.
So, Dr. Masinde, you should be her PhD classmate as well.
Yeah. Yes, it is time. She's just finished a fellowship, I believe. So she's like me. She likes school stuff.
Okay, you're scholars.
Yeah.
Okay.
Yes.
And she said the same thing. She said that you do a lot as gynecologists. You carry quite a heavy load. And I think we also talked about how a multidisciplinary approach actually would make a lot more sense because you're not the mental health expert, but imagine a collaborative effort. That would be awesome.
I'm doing so much of that now because I cross-refer so much. I really like remaining within my space, and I recognize that there's fields that I'm not a specialist in, and I tend to have the conversation and then refer.
Perfect.
Just refer.
All right. Next question.
Yes.
If you were to rate your top 5 medical specialties, which ones would they be and why? In the order you choose.
That's interesting because dermatology, for example, I feel like it's fairly easy and they're well paid relatively. Plastic surgery, they're well paid, but it's a lot of work. Obstetrics is very satisfying, but it's one of the 2 highly litigious. We get sued left, right, and center. So obstetrics and I think orthopedics are highest on that.
Okay.
But for me, my job is very satisfying. I wouldn't say it's the best to recommend to anyone to do, but
for you, it's the one.
I love it.
Yeah,
but I don't it doesn't come highly recommended.
Okay.
Yeah.
I wouldn't recommend it.
Yeah. It's lots of nights. There's no work-life balance.
That's
if you're
true.
an obstetrician, and it doesn't matter whether you're physical. There, we carry a lot of things even when we go home. Like I go to bed and I'm asleep and I'm like, oh, the magnesium sulfate is the patient, is the baby, is the mother, it's not, I would not recommend
That's true.
but it's very satisfying. How many are those?
Those are 4.
3. There are 4.
Actually, there are 5, including yours. Because you said dermatology, you said plastic surgery, orthopedics, and obs-gyn.
Oh, okay. I was going to add anesthesia. I think the job is so much fun because they're like pilots.
Yes.
The difficult part is getting you to sleep, which is like flying, and then bringing you back to. But in between, they're so
That's
chill.
true. They're just like, playing their crosswords.
And monitoring they just listen to the machines, and then they go out for tea, and they're so chilled. Their
and they look at the surgeon. They're just like, I'm watching you.
They're just like,
yeah.
So yeah.
But I realize anesthesia has quite a bit of physics.
Yes.
And
yes,
that for
and
me,
machines,
that was it. I was just like,
and gases and all that stuff.
Yeah.
I would not do anesthesia.
Yeah.
I wouldn't do anesthesia.
Really?
No.
But
they're very
enjoy it.
clever. Anesthesia and
They're so
pathologists,
smart.
because they have to know the whole body, like head to toe.
Another one, dentists.
Yeah, dentists, I feel like and I have relatives who are dentists. Kidogo fraud.
Choose
fraud
your
like,
words wisely.
Fraud like, because they do tests from over here up.
No, but remember they were in our anatomy classes. They were in most of our classes.
But they don't go deep. The toes and the nail.
But the thing is, imagine you doing dentistry and then doing medicine.
No,
I
if
feel like
did
they do a
dentistry,
double. Actually, they get a triple degree.
No, I
feel like they should.
You're just
dentistry,
you're biased.
medicine, and surgery.
You're only biased.
Okay,
No.
okay. I'll have dentistry and then I'll ask them, do you agree? So now I think you like this next question. If you won a grant today, what problem are you solving?
Oh. I'm solving women health problems. And it's ridiculous because I've been in this space for, I want to say, nearly 20 years. And I still get frazzled by how much we don't know.
Yeah.
And people don't talk about how much we don't know. And we don't fund how much we don't know. And I just get amazed that it's 2026 and there's stuff that we still don't know and no one is doing anything about it.
Yeah.
I would fund women's health research and make innovative products for women's health. When I say innovative products, I'm saying, like I like the menstrual cup.
Yeah.
It's a nice example, but it took so long to get to the cups. We've been on pads and tampons and playing around with cotton wools and different types of cotton wools for that.
Different types of cotton wools.
Different types. It's cylindrical cotton wool, it's flat cotton, it's pad, it's tampon.
That's true, actually.
Wool,
Yeah.
And something like the speculum, which we use for pap smears.
Yeah.
Until maybe, I want to say 5-10 years ago, it was just metal and cold and clingy
and
objects and uncomfortable.
Yeah.
And I was like, we have hysteroscopy, which is a camera that looks into the, we can go through the vagina and vaginoscopy. But we've not figured out how to sort out this speculum business. So things like that.
And that's a small thing.
Things like that just drive me crazy.
Yeah.
Crazy. HRT, medical hormone therapy, for example, for HRT. I like that there are many products.
Yeah.
But the implants, which we put some implants into the tummy, have only been recently approved, maybe a year or two in a Western country. We don't even have them available in low and middle income countries. So I feel like there's so much and it's taking so long to sort out all these problems. Yeah.
Okay. And I want you to hold that because we'll get to that. Okay. There's a conversation I was having yesterday on my TikTok about how, what is our problem? Is it that as women, we don't advocate for the change that we want? Is it that there's no funding, or is it that it just takes so long? So I think we'll talk about that. Yeah. All right. Next question. What's one skill or habit you feel you have that makes you a good doctor?
Listening.
I think even I say that. Yeah, even I say that.
I like, and I listen not for the problem. I listen because I like stories.
Okay.
Which is so, Like I listen to people and I'm like, oh.
Are you the ones you like the patients for? So when did your problem start? Actually, in 1990.
In 1990, I'm like, tell me. But that has also grown with age. Okay. I used to be very like, let's get to the point of the problem.
Yeah.
What
has brought you now?
So I still see my patients fairly quickly compared to some of my colleagues. Okay. There's a colleague I work with and she sees patients for nearly an hour and a half. I don't have that patience to listen to all those stories, but I like to hear how the problem has affected that person because that's what I like to solve. So you have a headache, I could give you medications, but how has that headache caused your problem?
Okay.
That is what I want to understand and solve.
It sounds holistic, which I like.
Yeah.
Okay. Then the last question before we start. So our episodes usually go up on Wednesdays.
Okay.
So Swahili Wednesday.
Yes.
Ukitumia lugha ya taifa. I know she's been in the UK for a while. Until UK.
And I come from Eastlands where we mix Swahili. Anyway, let's try.
Perfect. I wish I knew proper Sheng. I would have shembetenged you over here.
Now that one, you see, now that one is anyway, let's see.
So ukitumia lugha ya taifa, tueleze mada ya leo na dalili moja yake.
So now Ebu first say mada is the
Topic.
vision, the topic.
Yes,
okay.
of the day.
So mada ya leo na
Dalili moja, like a symptom of, yeah.
Mada is kukosa homoni. And I had this in my notebook last week because I was giving a talk in SWA.
Yeah.
Kukatika kwa hedhi.
Oh, so hedhi is hormones in...
No, hedhi is menstruation.
Oh, what?
Kikomo cha hedhi.
Wait.
Kikomo cha hedhi. Write that in your notebooks, audience.
Kikomo?
Kikomo cha hedhi.
Cha hedhi.
Yeah.
I feel bad that I didn't know and Eric knew. I feel bad. I should have known.
Take that. Even people just congratulate me. Those people who say my Swahili is bad.
Yeah,
you go.
You knew more than me.
Yeah.
To be honest.
Kikomo cha hedhi.
Okay.
Now one symptom. One symptom.
Dalili moja.
Dalili moja. Mifupa.
Mifupa is bones. What? Kuuma?
Uchungu wa mifupa.
Okay. Sawa.
I was trying to think joints.
Yeah.
That was not coming. This is challenging.
Sawa. All right. So now let's just go right into the topic of the day. We're here to talk about perimenopause and menopause. And I think for me, especially last year and maybe the year before, I think we started talking about it more and I started getting more questions around it. But I did not have the capacity to speak on it. So I was like, why not bring someone who is actually doing work in that space?
Yeah.
So how has your experience, actually not how has your experience, what drove you into now doing more research on menopause and just getting into that space? Menopause and perimenopause.
So three-pronged. My mother was the biggest influence.
Okay.
So when I was in med school, must about fourth year, my mom started developing hot flashes. And she would have them like just randomly. And she would be like, I just feel hot.
Yeah.
Just hot. Open the windows. She's walking around with handkerchiefs. And then one day I just looked at her and we've spoken about this in public as well. I looked at her and I was like, you have menopause. And she just turned, she's like, what is that? And I explained what it was. I was like, your hormones and this. She was like, hold that thought. She called her sisters, all of them, and sat them down.
Yeah.
So that was also one of my beginning careers of talking to women.
Health talks.
Because they called each other, they sat, I was just explaining these things and their jaws were on the floor. They were like, sorry? What is that?
Yeah.
When did it came when? What? Then I'm like, but even my grandmother now, I was like, she's been in menopause for so long, all her hypertension, diabetes, heart attacks, she's had 3 heart attacks. They were just like, that's menopause. I'm like, yeah. So then I realized they had no idea what this was about. And I had very sketchy information, which was from the teacher, which was exactly 1 hour or less.
Yeah.
It was just very much in passing. So anyway, I remember now going back to read and going like, okay, so the symptoms, usually they come at around the age of 50. The symptoms would last like 5 or 10 years. So this is the information I passed to them. 10 years on, my mom called me. I was now an obstetrician and she goes like, you remember you told me those symptoms are going to be 10 years? Yeah, they haven't gone. So I think you need to go back to school and find out why they haven't gone. That's how bad they were for her.
I thought you were saying, I think we need to your degree.
No. Oh, she loves the fact that I did medicine and she trusts my judgment and things. But she was like, I think that 10-year mark, I've been tracking it. It's not 10 years. So that was interesting first. But then I went into fertility. So backtrack first before fertility. My grandmother always had these joint pains in her knees. And she told me, I was told it's arthritis. But for so many years, I'd gone through med school and internal medicine, we do arthritis. And I used to look at her joints, her bones. I'm like, this arthritis of hers, it's not reading the books. Her joints don't swell. Her like hands don't become stiff. But she's been told she has arthritis. So I used to be curious. I'm like, this arthritis of hers is so different. Maybe, So I packed that. I didn't think much about it. So then I became a fertility specialist. It was during my second year as a fertility specialist proper that I had a 30-year-old girl from South Africa who had flown into the UK. And the reason she'd come was she'd been trying to conceive with her partner. So then I said, we have to do some tests so that we know where we are starting from. And I was so disoriented when I saw her ovarian function. Her AMH level was 0.1, which is very low for your audience.
The normal
AMH
should be?
for roughly around 15. We get it even much higher when you're younger. People with PCOS will have it like even in the hundreds, sometimes 50s, hundreds. But it comes down with age, and I had not seen a young person. I see that in age 45, 50s. I'd not seen a young person with that. So then I started to just observe, but I remember the reaction of having to explain to her what that meant when she was trying to conceive. Like, you've come for a baby, I'm telling you there are no eggs, basically. So that's where my initial interest came from. So I started tracking my patients and seeing how many of these young ladies I was getting, and there was quite a number. I'd get nearly 2 every week.
2 every week?
2 every week.
Wow.
And this time I'm in the UK. So then I start asking my Kenyan colleagues, are you guys seeing a pattern? But because we hadn't been sensitized to it, no one was looking out for it. And it wasn't until I asked some of my colleagues, I'm like, okay, when you get your patients, and they may be just random, but just ask them to do an AMH level, which is what we do for fertility. And they started going like, I have a 37-year-old, I have a 35-year-old. And I was like, there's something there. So that's where my interest sort of came from. Now, in studying menopause and perimenopause is when I came to the realization that my grandmother didn't have arthritis. My grandmother had thin bones and thin muscles. And that's why she had this kind of bone pains.
But nobody realized it.
They used to give her anti-arthritis medicine. She had steroid injections several times. She had lots of calcium and vitamin D even when she was like much older. But I was like, it never clicked with the way that we had read arthritis comes.
Oh, okay.
So that's where I am at the moment. Yes, understanding that, and then understanding why my mom, for example, had the symptoms for more than 10 years.
So now, maybe we've jumped the gun. Tell us about perimenopause and menopause. When do they start? What are they? Who is more at risk? Is it a disease? Is it not?
So if you live beyond a certain age, you are going to be in menopause.
Okay, you started off, hey, if you live.
Yeah.
I know.
And medicine has become so advanced, so we're living longer.
Yes.
Which is why it might look like it's a new thing, but it's not. It's just that people are living longer. Therefore, we are getting to the point where our ovaries are finishing the job that they had been designed for. Otherwise, people used to die in the older age. Life expectancy used to be like up to the 40s. So now when you're getting to your 50s, 60s, 70s, we're getting people who are living longer in this thing that is called menopause. Okay. Menopause is 1 day, which is what people don't realize. It's just 1 day.
I say that to the camera.
Menopause is 1 day. It's sort of highlight event. It's just a day. And it is the day from where you haven't had a period for the last 12 months. Okay. So there will come a time. So let me explain with perimenopause and menopause. I like to use my hands, by the way.
These are still over there, actually.
So you have a day, and you have the time before that day comes, which is 12 months. And we haven't found a nice way to define it, but that's how it's defined. So in this time before, it's all perimenopause. But the distinction between where perimenopause starts and where your normal periods are is the changes in the period cycle length. So when you're young, when you're in puberty, you get periods that start and they're erratic. They come sometimes, they don't come sometimes. Then they start to become regular, usually in your 20s. And they will be regular, i.e. they come every between 21 and 35 days. For most people, it's 28 days, and they don't jump. People will be like, my period comes exactly on the dot 28th day. Then there gets to a point where the periods start to come closer. So you who was a 28 day starts to get 26, 25, 21. So they come, but they're coming more frequently. Then they start to space out. And that process can be anything between 2 and 5 years. So they start misbehaving. I call it misbehaving because you don't know when the period will come.
So it's irregular?
It's irregular. So it can come 1 month, then it comes 40 days, then it comes 60 days, like that. So it keeps spacing out until one time you miss a period and it will come maybe after 6 months. And then it disappears and doesn't come for a year. So when it hasn't come for 12 months, that day you mark as menopause.
Okay.
Anything beyond that, you're in menopause, or some people will then call it post-menopause.
Okay.
Yeah.
Is there, sorry, let me just interrupt you. Is there a chance where you haven't had your periods for 12 months and then on the 13th month they come?
If that ever happens, we want to evaluate,
Okay.
because you should never get another period once you have not had a period for 12 months.
Okay.
So we want to evaluate, because there are causes of abnormal bleeding in people who are in menopause. The most common is thin, the tissues around the vagina are thin, so they break easily.
Yeah.
But the more dangerous is cancers.
Okay.
So there's a difference.
Yeah.
So the most common reason is everything is just thin because there's no hormone. But the more dangerous, what we're more concerned is cancer of the cervix and cancer of the uterus.
Okay.
Yeah. So if you've not had a period for more than 12 months, it comes 13th month, you need to see a gynecologist.
Okay.
Don't sit with it and say, oh, my periods are now back.
Yeah. And I'm happy. Like,
And I'm happy.
get that
I
checked.
hadn't seen them, but now.
No. Sis.
You have to get checked. Yeah. And
Right.
any other bleeding after that
Yeah.
is usually abnormal.
Yes.
Yeah.
Okay. Yeah, we call it abnormal uterine bleeding, yeah? Now, for perimenopause, is there like a defined age range where it starts?
So coincidentally, it can start, like I said, 2 to 5 years. I'm now having patients even 10 years. So what we used to say traditionally is that you might have your menopause or go into menopause around 51 years. That's no longer holding true.
Okay.
It's coming earlier. It comes earlier for African women and people of African origin.
Okay.
And then if you count a 10-year advance, so say you would go into menopause 45, then any time from the age of 35, you can be in perimenopause. I know. Hold your jaw. Don't drop it too much. But yes.
So was that too close? Oh my goodness.
Yes.
And what are
So
some
it can start anytime from that time.
Okay.
Yeah.
Okay. Wow. Hey, okay, fine. That's too soon. Too soon.
You can sip some more, child. Yeah, I know.
Like this way. So what are some of the symptoms you would see in perimenopause?
So perimenopause and menopause in itself, other than this period abnormalities, comes because the ovary, which is where the eggs come from, they produce a hormone. So the cells in the ovary will produce this hormone called estrogen. So estrogen, usually the hormone lands on some things called receptors. In science. We for those who understand what that is, it's a space where the hormone comes and talks to the tissue.
Yeah.
That thing is called a receptor.
Yeah.
We have estrogen receptors everywhere in the body, from the hair follicles to the eyes, to the ears, to the tongue, everywhere. There's estrogen receptors even in your bowel, your toes. So when there's no estrogen, that's where the symptoms will come from.
Okay.
So hair can fall, eyes can become dry, hearing, you can lose your hearing, or it becomes harder to hear, changes in the nose, smell, taste. Some people it becomes more, some people it becomes less. You can have your heart pumping, palpitations, you can have hot flashes, but you can also have cold flashes, which people don't talk about. So you feel like it's really extremely cold. You can have breasts becoming smaller, saggy. You can have your skin becoming very dry. So someone tells you, oh my God, my skin products have stopped working. Skin is very dry, getting acne. You can have bloating, constipation. So if you think of any body system, you can have symptoms in all those. You have urinary tract problems, so you pee more frequently, you pee less amount of urine. You can have dry vagina, so it becomes very dry, and intercourse becomes very painful. You can have bone pain, like I spoke about with my grandma. Muscle loss becomes very thin. So the whole body has estrogen receptors. So that's where the symptoms usually come. And different women will experience different symptoms. So this is one of the things that is very important to understand. Because just because you're not experiencing a hot flash does not mean you're not going to experience something else. You can experience something else.
Okay. Now there's this question. I have a few questions here. So we asked our community on Instagram. We call them Adopt Tribe. So you can join us, please. We have a community on Instagram, and they had some questions. And I think there's one thing I've been seeing trending, and especially because of now like the HRT now being approved and a bit more recommended for women in menopause. So there's a question about your lips. So does your labia actually disappear?
So disappear is a bit of a strong word,
Yeah.
but yes, they can become really, really thin. So the tissues around we call that whole area is called the perineum, that whole space. So the lips themselves are tissue that is, I don't say like the breast tissue, but there's some bit of fat and some small muscles. Again, like I said, everything has estrogen receptor. So when we don't have estrogen, you get what is called atrophy. So they become thinner. They can disappear. For some women, it's been very dramatic. They even flatten out.
Yeah. And see, babies, your anatomy kind of resembles a
Like
baby's anatomy.
But the babies usually can be a bit more plump because they've come from the mom. If the mom had estrogen, then they can look even more plump. They're flat, but they're plumper.
Okay.
For older women, they're thin.
They
can actually just thin out. So where you could see the labia properly and hold them, they become thin. Like they can be paper thin.
Okay.
Yeah.
Now you mentioned breast and how, of course, you lose the fatty tissue. Now I have a question for women who have implants. What's that like for them? Do they take them out? Like, what's that like for them?
It's funny that I saw something on Instagram about how the archaeologists of 2050 or something like that will be finding people in the graves.
It's true. Yeah, because they will survive.
They will
decompose and then they'll just be
just
there.
sit over there. And I think for the guys, they had some penile things.
Yeah.
Anyway, that was funny. We don't have a lot of data on what is going to happen in the future, i.e. with implants, because this is not something that's been there for a long time. But also remember, we haven't been studying women.
That's true.
And their health for very long time.
Mm.
The breast tissue will disappear, and whether the implants will then sort of become more adherent, it's very difficult
to tell.
Yeah.
Okay.
But the breast tissue will thin out.
Yeah. Okay.
So
now,
they may look pucky, but the anatomy
and
itself,
sometimes like even more saggy.
Yes.
Because it'll fall a bit, and of course the skin also thins.
And I think the plastic surgeons, good plastic surgeons, will discuss that as well.
Yes, actually, I feel like, and now as we're talking more about menopause and perimenopause, it affects almost every specialist field.
Yes.
So everyone should be talking about it.
Everyone should be talking about it.
Okay.
Yes.
Now I had a question. So yesterday I had a conversation on my TikTok, and this conversation stemmed from a lady who was talking about how midwives and nurses are not comfortable helping a woman deliver in a position that they have not been trained in. And she was wondering, so why are we still delivering in lithotomy and all these old positions when there are others that are a bit more comfortable? So her question was, is it because as doctors, we are not voicing some of the women's concerns and suggestions or recommendations? Or number two, is it that there's actually no funding to be able to pour into that research? Because of course with medicine, everything is research based. And then the last thing she said, Ama, is it that these things just take so long for change to be effected? Yeah. And you're talking about how like even the speculum, it's taken so long. By the time you got some of these hormone replacements for menopause, it's taken so long. So what's your opinion on that?
I think first the acceptance of how things are. And I used to get very offended. I still get very offended if I walk into a hospital or a maternity unit and they go like, this is how it's been done. In my head, that's a culture that doesn't accommodate for change and thinking. Like if you walk to your workplace and say, this is what has always worked and it works that way, then people take on that culture. So the same, like with the speculum, we found the speculum, it was metallic. We used the speculum. In my time of training, I used to warm the speculums. And the midwives and the nurses would just be like, this Dr. Muchiri anapenda hii, she likes these fancy things. I'm like, do you realize it's cold? It's a cold metallic object in a very warm area, and it's hard. It's very uncomfortable. Then, we used to put gels on it for lubrication. So then the plastic ones came along. A bit of an improvement, but even the plastic ones can still be cold. So I still warm my speculums before I put, and now it's standard.
How do you warm it?
With my hand or under warm water.
Okay.
I have now warm gel in the clinic so that I can warm that.
You're fancy.
As well. Because two things is probably because I've experienced what it means for speculum to go there. I have an understanding when my patients say it's uncomfortable.
Yeah.
And not to put the guys down, but they've not had a speculum.
Yeah.
They found the speculum in the way that seems the guy who made the speculum delivered the speculum. So I feel like that's some of the things that, as we experience these things ourselves as well, being able to say it doesn't have to stay like that. It doesn't have to be that I have hot flashes and I cannot wear my clothes are drenched and that's just how things are. Some of the institutions I've worked in, the women have been the ones to advocate for their clothes to be changed because the labor ward is very hot. Very unlikely that you'll have windows open and fans and things like that. But the clothes for the midwives were always heavy, like the scrubs. No one had thought, let's have breathable scrubs until the hot flashing women said, I can't work because it's too hot and I'm too sweaty. So it needs more of us to find what to do about the discomforts that we each face. And that's part of where businesses should be thinking. What is the problem and how am I going to solve that problem? And it may be a me problem, but there's always someone else who's going to experience that problem.
That's true. When you mention businesses, do you mean like health-focused businesses or just in general?
Businesses. All businesses in general. Like if you think about, answering the question for like treatments, for example, until maybe 2 or 3 years ago, no one had considered that breast cancer patient women get their hot flashes also because of menopause, but the medications that we give them are also anti-estrogenic.
Oh gosh, yes.
So then we can't give them menopause hormone replacement estrogen therapy. But until 2 or 3 years ago, no one had thought, what else can we do then? So women just used to be told, suck it up, it's, sorry that you have breast cancer and that we have to give you anti-estrogen medications. Gratefully, there's more people who are thinking like that. Like think about what is that problem and then solve that problem. Whether it was because the breast cancer patients had not spoken up, they're dealing with many other things, or it's clinicians not thinking widely about what is this problem. And that brings me back to when I ask my patients, you have a headache, how is that affecting your life? That's more interest to me than giving you paracetamol and a painkiller.
Okay. I like that approach. I really do. Now, what are some of the maybe treatments for menopause and perimenopause and also the new advances that we've had? Because I know HRT, there was a big announcement last year. Maybe you can talk about that.
So the big announcement for HRT, so first we used to call it hormone replacement therapy, and the wording has changed to medical hormone treatment.
Medical
MHT. And these words will keep changing as sort of things go along, but the gist of it is that the estrogen is low, so we give back the estrogen. That's the essence of the medication. If you have a uterus, it means that you can still bleed. We don't want to give you too much estrogen because too much estrogen is a risk factor for cancer of the endometrium, which is the womb lining where we bleed from. So if you have a uterus, we give you progesterone, which is the second bit of the hormone of the cycle in a woman's cycle. So that's what the replacement therapy is. Basically taking what you don't have and giving you a bit, and then supplementing the progesterone so that you don't get endometrial cancer. If you don't have a uterus, we don't need the progesterone, we just give the estrogen. And the estrogen is actually a very small amount. You have much less estrogen in medicines than you do when you're having your normal cycle. Your normal cycle will usually have like 1,000 internationally. It's quite high, but some people 500 to 1,000. So when we're replacing, we're not aiming to get you to ovulation level. It's just a bit to tide you over the symptoms, but also for long term. The types are different. So we used to have a lot of tablet-based ones. We now have patches, which you can put on the skin and you change every twice a week. We have gels. You can apply a gel on your arm, on your gel, like the sanitizer gel. Just a pump or two, depending on what your doctor assesses. One of my most fun ones is the implants. Because the implant, you put it like over here. We call it the right iliac fossa or the left iliac, wherever it is, just under the skin. It's like the implant for contraception, but it's tiny. It's like super tiny. It's like magic. It stays there for 6 months. So then you don't have to think about it. You don't have to,
So after 6 months, you remove it and then get...
So it gets absorbed. So it's a small pellet that just keeps
now
getting
this is
absorbed.
where birth control needs to catch up.
Yes.
Yeah, because why do
this
I have
one
to
you
come
have
for you to remove it?
Yeah, this one is super tiny.
Yeah.
And it's the medicine in itself
Okay.
rather than covered in.
Yeah.
This one is covered in like a plastic thingy.
Yeah.
What else?
These are creams. Yeah.
So the creams are, we have vaginal estrogens, which are separate from systemic, which is in the system.
Yeah.
Vaginal estrogens can be given to everyone who needs it, including patients with breast cancer.
Okay.
Yeah. And they work locally in the vagina to reduce the symptoms. There's something we call genitourinary symptoms of menopause. So that is dry vagina with painful intercourse and bleeding, part one, but also urinary tract infections and recurrent infections in the urinary tract because of the dryness.
Okay.
So these vaginal modes will usually help sort that out. And there are women, that's the only symptom.
Yeah.
So they don't have anything else, but they'll come and they say, I'm just itching all the time. And they get treated so many times for yeast infections, and a lot of times it's not a yeast
and this
infection.
other one, do you remember lichen planus?
Oh, yes.
Yeah.
That has to be checked. So lichen, planus sclerosus, there's changes in the skin. In vaginitis for menopause, there's no change in the skin. You can't see like colors or whatever it is. There's no boundaries. So, and you can give vaginal estrogen. So there's creams, there's a tablet, there's a pessary, there's a ring. I love them.
Yeah.
They are so cool, those vaginal things. They really sort out my patients because it's very distressing.
Patient advocate.
Yes.
Yeah.
So when they come and they go like, I don't want to have intercourse, it's too painful and all that. And they're just like, pop in something there, and they come back and they're like, oh my God, magic.
Yeah. When do most of your patients come to you, especially the perimenopausal and menopausal? What's the main symptom you commonly see?
So first, when they come, perimenopausal women don't come, and I'm hoping that this is a conversation that we make more prominent, because if you want to do anything, is to prevent the problems from starting to happen or reduce the risk of them happening. Perimenopausal women don't come to see us because first they don't know they're in perimenopause.
Yeah, you say 35. Honestly, at 35, I'm not 35, expecting.
You are really living your good life.
Yeah, and you say that those are still the productive years.
Exactly.
Yeah.
So if you know about your body and you've been having these conversations for long, you are expecting and anticipating something. So when your period starts to play around or start to get hot flashes, you don't start blaming the weather and climate change and all sorts of things. It comes to your mind that, it could be perimenopausal. The women who come are already in menopause. So most of the patients who come are already, sort of in their menopause, and they've been really struggling a couple of years, sometimes even much later. I've had patients in their 70s coming to say, I didn't know there was like things to do to help me with this. By the time you're 70, you're coming because of bone pain, you're coming because of your heart and heart problems. You're not coming because of the hot flashes. But in perimenopause would be a perfect time, even earlier. Like when you start getting into your 40s, start prepping. It is coming. And everyone who lives long enough, like I said, every woman who lives long enough will get into perimenopause and menopause.
Okay. I want us to transition to now, how do we live with menopause and perimenopause, and also how do you care for someone who's going through that? But before we get there, let's talk about the black box erasure when it comes to HRT. I think part of the announcement was they removed the black box warning or labeling. And where did that come from?
Okay. So for us to be able to understand how these things work, they're big countries with big noise and big, which is the Western.
We're also a big country, by the way. Where's my camera?
Us guys are a big country.
Yeah.
We need to make more noise about all the things that we do. You know that magical Kenya selling equivalent now in medicine.
That's the noise we need to make,
People across the world know about Kenya and tourism and the Masai Mara.
Oh, yeah.
So Americans are very science forward. They've been very advanced for many years. So one of the big works that happened in the 2000s was a Women's Health Initiative study. And that's where a lot of our problems came from. So even now in my practice, we have women who were already using HRT because they were on HRT before. Those women are now in their 80s and 90s. So I've got patients who are in their 80s still on HRT, and they're like, I cannot stop it. And then the announcement in 2000 came from a misinterpretation of the figures and the data that was coming that made a suggestion that HRT was causing breast cancer, which wasn't the case. HRT, you will get breast cancer if you were to get breast cancer. So I recommend any woman above the age of 40, please make sure that you're looking at your breasts, examining them yourself, having your ultrasounds or mammograms. Whether you start HRT or not, you're at risk of having breast cancer because you have breasts. This is the most basic. There are other risk factors that will increase that: obesity, smoking, diet, family history, but you're already at risk. When they looked at the data and suggested that it was the HRT that was causing the breast cancer, then people panicked, doctors included, and the women, the population. What then happened is that a few of the doctors who have continued to go like, this can't be, because we still had so many other women who are on HRT, they kept pushing for, let's look at that data again, let's look at why it's happened, let's look again into that data. And that took years before it was done. And they faced a lot of resistance. So in that period of 2000 to nearly 2021, just around COVID time, there's been medical school training that has omitted talking about hormones therapy. So we are taught about contraception, which are still the same hormones, estrogen and progesterone, but no one was talking about what to do with menopausal women. So that's where that gap has come from. And that fear, that's where it came from. So the black box warning removal was to now say, because all the medications that were HRT termed had these warnings of it can cause breast cancer, can cause breast cancer. So when that was removed, then they made that announcement. It's still not encouraged people that much, and that's why we have to keep having this conversation so that we can break down what that information was and reassure patients that there's still opportunity and not everyone has to go on hormones.
Okay. So we'll keep yapping. We'll keep yapping about it so people can know and understand. More and more
people can know.
All right. So now just to wrap up, before we go to like the last segment, Kabisa, how do we support women who are going through perimenopause and menopause? And also how do they adapt to live in that transition?
So I think the first thing is just having these conversations. Because even in my clinic, there are patients who just go like, okay, now I know what it is. That's fine. I can deal with the symptoms now that I know what it is. Their partners also don't know these things. So if you don't understand and then you have a husband or a boyfriend or a partner who just thinks you're crazy, then it becomes very difficult. But she never used to be like that. Guys go like, this is not the woman I married, you know? So it's important for just the first basic understanding what is happening and why is it happening. Then adjusting your life to that. I think these are conversations that should even be had with girls who are in their 20s because I think we're waiting too late. Because what happens in menopause and perimenopause is the biggest things are the heart, the bone, and the brain. Those are the things us as doctors we are concerned about. Your hot flashes you can deal with unless they're now interfering with work and sleep, which makes you very tired the next day, and then you get moody and you get very irritable. Vaginal symptoms will be a personal problem. So from a medical perspective, dry vaginas is not a problem. Okay. But for the women, it is a concern. So understanding what to do with your life and your lifestyle will be useful for us. So what do I mean? Diet. A lot of women above the age of 40 are under high stressful conditions. They're taking care of their parents. They're also at work. They're managing so many things. And then they also take alcohol when they get home. They don't get enough sleep because they're handling all these things. They don't eat properly because they're very busy, so they'll be snacking on random things that are not healthy. They don't get to exercise. Why? Because they're too busy. They have work, they have family, they've got all these things. So it sounds like very basic things to adjust to, but if you've not been conditioned to, for example, go to the gym or train, run, whatever exercise you want to do 3 times a week, you're then getting to 40, 45 and getting shocked.
It's going to be harder.
Yes, and it's going to be very difficult. So if it's a pattern that you have established from when you're in your 30s, that I train 3 times a week. And I don't train because I'm going for a marathon. this becomes your life. It's a lifestyle.
And I like that I'm seeing that more.
Yes.
I think
Yeah.
more
People
of the younger generation. I think I would say from like 20 to 40, a bit more intentional about their physical activity. So kudos to you all. Keep it up. Keep it up, guys.
Keep up.
Yeah.
So if you think about like our grandmothers who are very active, they used to carry heavy loads, they used to go and fetch water from the river, they used to walk long distances. It was very different from this population who sat on their desks, on the computer, driving and sitting in traffic for long hours. That demographic is struggling more with symptoms than now our grandmothers. And the people who are being intentional will probably have an easier time when the time comes. So yes, exercise, diet, alcohol is a big deal, smoking. And I put that vaping business there because we don't have the data.
Yeah,
I'm convinced even that vaping is not helping us, but let's wait and see what the data looks like. And then, mind and mindset.
Yeah.
So people who have had mental health struggles will have more mental health problems when they're in menopause.
Okay. Do you mind if I ask a question?
Yeah.
If you have PMDD, will it influence now your menopause or perimenopause?
How it comes?
Sorry.
Yes. Because the hormones in PMDD, and I put that PCOS into that basket as well, they will experience their symptoms differently because of what their body is already used to and what their body was doing. So it's good to be aware about, like even PMDD and the mental health aspects of that, so that you're aware of what happens when menopause comes. So just being mindful and being aware of your body. I think it's a lot about listening to your body. What's my body saying now? And then what do I do with that? If I'm sad for 2-3 days, if I'm sad for 5 days, reach out to someone. You shouldn't be sad all the time. Okay. And we have a lot of women who can be sad for months.
That's true. Yeah. And that is a problem. And then for endometriosis and fibroids, menopause is more of a positive for this.
Yes, because now the hormones are less. But we also have women who, especially for the perimenopause, can be very difficult. So remember, perimenopause is erratic. It's not a... So that's a problem. Because if you have endometriosis, but every month there's going to be a period, that's easier for your brain to sort of prepare mentally than it came this month and now it's not come for 3 months and you think, whoa, I've had a break, and then it comes again. That erratic can really throw off people who are in... who have endometriosis and fibroids.
But they tend to do better
once
after
the periods,
menopause.
Yes, once the periods come. Stop completely.
Okay, now before we move to beyond the clinic, I think we've covered a lot and we can't exhaust this topic. We are just beginning. We are just scratching the surface like this. Maybe tell us, how long should menopause last?
Wow, it can be anything. Now I've even stopped giving it a timeline. Because it can be anything. Like I mentioned, my mom's was more than 10 years. I think she maybe 18. She's nearly in her 70s now. She still gets a bit of hot flashes, but now they're manageable. Only just maybe in the last couple of years. So I don't want to make promises that it's going to be.
So you haven't been able to answer her?
No, I just tell her we just play by ear. Which sounds really bad, but different people will have different symptoms and different lengths of it. We now know that we like to... The world says black women. I don't like that, the word black. I don't know why. I don't know how I feel about it. But anyway, African women and women of African descent will have longer, more severe symptoms. So a longer period of time and more severe symptoms. So if it's hot flashes, worse. If it's joint pains, worse.
Okay, I've just remembered something and we can't end without talking about it. What about at the workplace?
So a very good friend of mine, or maybe two even, very high flying, very high achieving women at the peak of their careers left because they were sweating in the boardrooms and the guys were just like, are you fine? Do you need a minute? They were thinking that they're not confident at their jobs. So their confidence got hit. These are high level, high profile, high achieving women leaving work at their prime, when also the workplace needs those type of women because they offer wisdom. Someone who's been in an industry for like 40 years, they have so much wisdom to give. So workplaces really, really need to adjust. And I say that categorically. what I've found is that because the conversation has not also been had in workplaces and with men who tend to be the bosses or whoever is in charge, they don't understand this thing. They don't understand what's happening. They don't understand why she has brain fog. I told this woman yesterday to do this, and she's forgotten, or it didn't click. So a full.
I'm so sorry. I've just thought over TikTok, and Eric is going to judge me. So there's this TikTok for Justin Bieber. Is it not clocking?
Yeah. That's guys. They're like, come on.
Yeah.
So women are not choosing to be, sort of all over the place or daft or have brain fog. They say that they don't recognize themselves even for themselves. So workplaces are adjusting to make it better for women who are in the workplace, but also women in the workplace.
Okay.
Advocate for yourselves.
Okay.
Advocate for yourselves and say, I am now having a hot flash. Let us open the windows, please.
Yeah.
Without being aggressive. I remember there was a place I worked and one of the ladies was menopausal. And she really used to put that air conditioning and kill all of us because she needed to cool down. But having an understanding and having people have these conversations in the workplaces and having a space. If they need to work from home, a lady who is in her 60s who has been in the industry for 40 years is not going to sleep the whole day because she's working from home. Just let her work from home. Don't force her to come into the office sweating and all those things.
That's true. Adaptability is key. Yeah. All right. And I think insurance providers as well, because now we're talking about HRT.
I've been making a lot of noise about that. I hear that some of them have started. Okay. I'm not very sure about
we hope to see.
And because again, it comes to that cost that women have to bear. We bear so much cost when we're having periods. So period products and pain killers throughout our lives. Then that ends, and then now there's new payments for hormone replacement
because
therapy.
My bones just need to remain healthy.
I think we need a break.
We're forever transitioning.
Yeah. I'm like, why? Let's find ways to make it easier.
Yeah. But I think there's something you mentioned even before we started shooting, that maybe we also need to start putting in money as women. To fund research that actually benefits us, because we are constantly saying there's no money in women's health research. Maybe we'll reach a point where we're just like, please, here, take my little monies. And if I give my little money, you give yours, someone else gives theirs. And there's so many women in business as well. I think there's an opportunity there.
It makes sense. Because if you look at the beauty industry, for example, how many women entrepreneurs have gotten into food?
$1 billion.
Yes, food and supplements and products, makeup, beauty products, hair. I'm like,
that means there's money.
And there's women who are entrepreneurial, enterprising. We could sort of think about that from that perspective, that I know that I'm also going to get into menopause one day. Let me start putting some bit of money into research for that. And the thing I need to explain is also research. People think that research happens today and tomorrow there's something. It can take nearly 7 to 10 years for a product to be researched and accepted as safe for use. Everything will have some side effects. So that's what research is about. We are asking questions. What are the problems? How do we solve the problems? And then there's research and development of products. And it can take 7 to 10 years for medication to come out onto the market. So if you're a woman who is 35 now, you better be putting some money, because in the next 10 years, there needs to be products that help you when you're getting into menopause.
And even just looking at it, maybe let's say if I was a business owner, I owned like a makeup brand. I want my customer to also reach 70 and be comfortable and like wear my lipstick nicely, my makeup nicely. So there's an opportunity there, guys. You can start here. We have menopause and perimenopause research going on. PhD Kwanzaa.
Yes. We need money.
And I think we'll keep talking. We'll keep having these conversations. All right, now that we've said we're always transitioning, let's transition out of the doctor's seat to beyond the clinic.
I've gone out of the clinic.
So now I just have a couple of questions to wrap it up. Don't overthink them, just answer them like this. Okay. So question number 1, if you had to text one simple, actionable health tip to all your patients right now, what would it be?
Lift weights, strength training.
Oh, okay. All right. That's it. Is there a why? Can I ask why?
Because the more you strength train, the more you build strength for your bones.
Okay.
For women, and even for men now, we are
Yeah.
seeing it, there's bone loss that happens. And the bone loss comes because we are breaking down more bone without building new bone.
Okay.
So if you already start off with good density of your bones, when you start to lose, that loss will not be the same as someone who's never exercised or never done any weight training of any kind.
Okay.
So that's why.
And the same applies to your muscles as well, yeah?
Yes.
All right.
Yes.
Next question. What's the first thing you do in the morning or the last thing you do before you go to bed that's just for your sanity?
I do many things in the morning,
Okay.
but I have nearly 5 hours to myself in the morning, which is what people don't realize. So
Okay.
I'm an early riser,
Yeah.
but doesn't mean my body is awake.
Because
My
you said
mind is
it's not
awake.
open for the public.
Yeah, nope. I engage with humans from 10 o'clock actively, but I'm up at 5.
Okay.
So the things that I do when I wake up is I pray, I write. I'm doing this thing, which is very cool. It's not journaling. I empty my brain on a piece of paper.
Okay.
I can throw the paper away, but I empty it. It's brain emptying. So sometimes I have nothing. I can write nothing for 2 pages.
Wow.
Then I go like, oh, I've just remembered I need to do
Something.
this and something and like that. And I
Yeah.
just brain dumping.
Okay.
I don't wake up with my phone. I don't sleep with my phone. So I don't wake up with my phone. So by the time all the things are happening in whatever countries they're happening, I get that information very, very late. And my theory is that whatever we think is news is not news.
Okay.
So what I mean is, if there is, let me use an example, yesterday or day before yesterday, there was an accident in Kibra, Langata,
Okay.
Southern Bypass. So you don't even
I
know,
don't know.
but it was news.
Yeah.
It will affect the people who are there at that time.
Yes.
Me having that information at 8 o'clock or 9 o'clock in the morning when I'm in my bed and starting to worry about the people and all these things does not add any value to my life. So I don't sleep with my phone, which is very nice. I have enjoyed that time of my life.
Teach us your ways.
Probably 10 years now.
Okay.
I don't sleep with my
Hey, Nabada, you went to TikTok.
Other people can do the things. I will not manage. I have no.
You're not doing it?
No. Yeah.
All right, next question. Is there a time, either in your training, your practice, or just generally in life, where you've thought, the body is so wild for doing that?
Pregnancy and delivery.
Someone who gets it. Someone who finally gets it.
That thing is like magic.
Yeah.
I say it's a miracle. And people assume
really
that,
is.
yes,
Yeah.
people assume that just because they get pregnant, then they get a and a baby comes. I'm like, yo, the things that could happen in that time, wild.
Yeah.
Wild.
Yep.
And then that the uterus, which is like in normal size, like an orange or a fist, like very small,
Yeah.
becomes this thing that can carry even a 4.5 kilo,
Imagine.
human, and the cervix is just 3 centimeters, remains closed the whole time for most women, not all women. And then one day it will just
decide to
open and thin, and then this 4 point or 3 point whatever human will just come out, and then the uterus will just go, and I'm like, yo,
and go back to normal. Like, isn't that magic?
That is like the best.
Yeah.
There's nothing that
that's
can
true. By the
explain
pregnancy,
Yeah.
labor and delivery.
Yeah.
All right. Next question. What's a piece of health advice you either gave or you were given a few years back? It could be 10, 5, however many years, that you've kind of changed your mind on.
Oh, changed my mind on?
Yeah. Maybe not that you don't agree with it. You're just not inclined to give that piece of advice.
Oh, I thought you wanted me to tell you the one I've maintained.
No. The one you've not maintained.
I can't think now. That's a difficult one.
Really?
Give me an example of someone who was like something you've changed your mind on.
Periods. Period pain. We used to be told, imagine it's okay. It's normal. It's part of the process.
So health advice.
Yeah. That you don't... Let me, for lack of better words, you don't necessarily agree with.
Okay. All right.
Yeah.
So let me use menopause as an example.
Okay.
Example. As an example. The social media now and how people are talking about menopause is very negatively placed. I think there's a lot of highlighting on the symptoms and, oh my God, and the brain, and it's going to do this. Whilst quite a number of women are sailing through it.
Okay.
And coincidentally, they're feeling some type of way for not having symptoms.
Oh.
Because everyone else is hammering on about the symptoms and this. So they're feeling like, am I abnormal for not having the symptoms? And then they cannot talk about their experiences easily because they look like they're being
insensitive.
Yes, insensitive or judging the ones who are having those experiences. So people will experience things differently. It's a bit like pregnancy. There'll be someone who will have a beautiful pregnancy, their skin glowing, they like being pregnant all the
They
time.
don't have the nose.
Another one, the pregnancy test turns positive, they start throwing up and throw up for the whole 9 months. It hit it. So I feel like, as particularly, and there's quite a number of women who don't have symptoms, and they can be made to feel othered.
Okay.
Because they're not having those symptoms. So they don't talk about the fact that for them menopause has been smooth and easy.
Yeah, I think social media tends to do that. Sometimes when you have a defining experience, it's like you can't talk about it freely. Okay. Then the last question is is there a health choice that is probably not one you would recommend? So it's a negative health choice or health decision that you feel like everyone should just break every now and then, at least once. Maybe you should have a cheat meal once a week.
Oh yeah, actually, I like that. I like the cheat meal one because life is short, man. I say this because I had a very nice burger day before yesterday.
Okay.
And it was so nice. I had half of it so that I could preserve the other half for yesterday, but I didn't eat it till I had this morning before I came here. But don't eat burgers every day, please. Please. I think this is the problem with like the, sweet things, like the things. Someone, I think my mom said, you doctors, everything that is good is the one that you say it's bad. Everything is so nice.
It's not us. We're not the ones to make
and
the rules.
cookies. And I go like, you can have a cookie. The problem is that you cannot have 10 cookies every day, Monday to Friday, and expect that nothing will happen. The same, unfortunately, doesn't apply for vegetables. You can have vegetables all the time.
Yeah.
And there's a difference in just how they get processed. So yeah, I like a cheat meal.
Okay.
I was going to use sleep as an example, but no, I think you should sleep enough, please. There's nothing
There's
as
that
bad
one
as-
day you'll have a deadline that you just have to catch.
Yes.
And it's fine.
It's okay.
It's okay.
But don't make it a habit of
Yes.
sleeping 2 hours, 3 hours. It's not
healthy.
It's not healthy.
And it's not, the results might not be seen now.
They can be seen later.
Yes. All right. So ni hayo tu kwa sasa tumemaliza. Now, if you have a parting shot or if you want to plug yourself, where can people find you physically? Maybe your clinic. The camera is yours. Which one? This one. The camera is yours.
Okay. Thank you for having me. First, that was so much fun.
Yeah.
Yes. Parting shot.
Yeah.
Parting shot. I'm trying to think of not so very wise, like...
It doesn't have to be related to the topic, to be honest.
This life is for living. Live fully. Don't wait for another day where you're going to have a nice cup of coffee or meet your friend or do those things now. Because, we don't know what life has in store for us. So live fully and do all the things that you have always thought of doing, even if you do them just once. I say that because I'm still trying to bungee jump, but I have not gotten there yet. But yes, live fully. Okay. Follow me on my socials, Dr. Dorcas Moshiri. As you have been told by the young people, I will be attempting to join TikTok. It is attempting to join. Let's see how that goes. Okay. And if you go online, I have a website and you can book a consultation there and we can see. I tend not to do a lot of consultations and especially in person just because of how my work is structured. I'm doing a lot of education and teaching. But if you're special, I may consider seeing you.
Hey, okay.
I'm very good at referring to other people. Yeah. Also because I like to capacity build.
Okay.
Yes. Yeah.
Sawa. Thank you so much for
And
coming.
I have a YouTube. Follow the channel also. The one it is coming. It is coming soon.
Oh yes, yeah.
I'd forgotten.
She has also a yapping session coming soon.
Yes.
To a screen near you. Yeah. Thank you so much for taking the time.
Thank you for having me.
I've learned a lot and I'll keep learning.
Yes.
Because it's true, by the way. I feel like menopause was that topic we're just like, next in passing.
Yeah, very much.
So we're still learning. If you've reached this far, thank you so much for tuning in. Please be sure to follow us on our socials. My name is Dr. Hope Simeu. You can follow me. We'll put them here on all platforms, or the ones you're on. And then also please subscribe. And what do we do on Spotify? Whatever we do, follow on Spotify, on Apple Podcasts, on social media. You know the drill. But yeah, that's a wrap.
Thank you.